Thank you. I'm Keith Linder. This is Tom Carlson, of course. Let me echo Don and Ricky's welcome to you. This is going to be a great session. I'm impressed by the speakers, many of whom have come from Europe to join us today. I think we're all going to learn a lot. The speakers are excellent, and I think we're in for a treat. We'll look forward to your questions. As Don and Ricky said, please write those down. We'll be looking those over and then asking speakers to address those. So be thinking about those and sending them up for us. So again, looking forward to a really promising and educational day, and glad you're here. Thank you.
I can only echo what Keith says. It's a pleasure and honor to be here. We're very happy to see so many people. It will be my job to introduce the first speaker, which will be Cyriel Ponsioen from the Netherlands, Amsterdam. And he will give us some insights as to the natural history of PSC and recent research related to that topic. So welcome, Cyriel.
Thank you, Mr. Chairman. Ladies and gentlemen, good morning. Let me first express my gratitude for being here. It's really an honor, and it's really, I admire the way you get all these people together. That hasn't been so in the Netherlands or in Europe so far, so there's lots of things we need to copy from you, and I'll keep a good look out what's happening today and in the rest of these. Do I need to speak up more? Oh, I do. So my task in the next 20 minutes or so is to guide you through some new insights into the natural history of PSC. So I will tell you some really new insights and some things that are out there already a few months or maybe even a few years, but I think worthwhile realizing. So these are my disclosures, and I just realized it's not complete. Thank you, Shire, for the breakfast this morning. When we talk about the epidemiology of PSC, this graph shows you that there's in fact little known. It's mainly the Western countries that, from which we have some idea about the incidence and the prevalence of PSC. Prevalence meaning the amount of patients out there in a certain population, and the incidence meaning the new cases every year per 100,000. And as you can see, that varies between 0 among Inuit Indians, very interesting, to about 16 in Oslo. And from many continents we have no figures at all. The same is for incidence figures, so the new cases per 100,000 per year varying between 0 and 1.3 per 100,000. And there's some data from New Zealand, but that's it. So in fact we know quite little about the occurrence of the disease worldwide. And when it comes to the natural history, how does the disease behave over time? We usually look at figures like this. This is called a Kaplan-Meier curve, which is an adding up of individual outcomes of patients until they reach a certain event, either death or liver transplantation or whatever you like. It's called a Kaplan-Meier curve. So it shows you the amount of time patients have until they reach a certain event. And this is one of the seminal Kaplan-Meier curves in PSC, composed by the late Ulrika Brumé from Sweden already 20 years ago, where she found that the time until transplant-free survival between individuals who are symptomatic when they're diagnosed versus patients who are not symptomatic when they're diagnosed is different. Patients who are symptomatic have a lower chance of not running into an event, transplantation or death, than patients who are asymptomatic. But more importantly is the median survival, because when you want to summarize graphs like this or analysis like this into one sentence, you usually name the median survival, which is when 50% of the patients here have met an event. So when we take these two together, the symptomatics and the asymptomatics, the symptomatics and the asymptomatics, you come around here, and then 50% is here. So at 12 years, 50% of the patients have met an event. So the median transplant-free survival in PSA patients was found to be, in this largest series to date, and at that time, 12 years. And that is more or less similar to what was found in smaller series worldwide in recent years. But it must be realized that all these series come from tertiary referral centers. That is, centers where they have a transplant facility. And that might introduce a selection bias, in the sense that the more severe patients might be transferred or referred to a transplantation center earlier than the patients who do fine and have no problems at all. So it might be that these figures, these median transplant-free survival figures, are biased and are maybe more gloomy than on average when you look to all PSC patients. Now this was a reason why we in the Netherlands a number of years ago started to embark on a large-scale project where we wanted to find a true population-based epidemiology and natural history of this disease. So what we did was, in our 70 million people country, we took half of the country, 6 provinces, comprising half of the population, and went to all the hospitals and looked extensively using various sources to find all PSC patients that were around and characterized them, looked if they really had PSC or maybe another disease, because the diagnosis is not always so easy to make, and ended up among 3,000 potential cases with almost 700 PSC patients. 1,590 of those were living in that previously defined geographic region. So these were taken to define the true population-based epidemiology of this disease. And what we found was, first of all, that the prevalence, where's my pointer? Here. The prevalence was not as high as was previously reported. So at least in the Netherlands, it was 6 per 100,000 and not 12, although we are quite similar to British and Scandinavian populations. Also, what we found was that the prevalence was slightly rising. So every year there were more people, slightly more people than the year before, and it was due to a rise in incidence, so new cases per year. There was a slight increase in incidence over the years, which was significant. And it is probably due to the still rising incidence of patients with inflammatory bowel disease, ulcerative colitis and Crohn's disease, which is, at least in our part of the world, still rising. With regards to the age group incidence, it was the same as has been reported all over the world. So the peak incidence is at 40 years. And there's almost 2 times as many males as females that are afflicted by this disease. This is the most important graph from our study, which is again this Kaplan-Meier curve, estimating the transplant-free survival in our population-based 590 patients. And when you then want to summarize this again with the median transplant-free survival, you go from here to there, you will find that it's not 12 years, but 21 years. So when you take all patients, also the milder ones, then the average transplant-free survival is much longer than it is when you look at tertiary referral center cohorts. Also, small duct disease, so PSC, which you cannot see on a cholangiogram, but only under the microscope, do much better than patients with large duct disease. And then we wanted to see if our hypothesis that this difference between the more gloomy transplant-free survival and what we found in our population-based cohort is indeed due to tertiary referral bias. So we went to the 3 transplantation centers in the Netherlands and again took all their PSC patients, part of which were also in our population-based cohort, but that's no problem. And we could collect 450 patients, and then what we found was in those 450 patients taken from transplantation centers, we found a much lower median survival of 12.8 years, similar to what has been published before in many other series. So that more or less showed that it is indeed what you look or where you look is what you get. If you have a patient that is referred to a transplant center because he or she is not doing very good, and you want to counsel him or her, what is your average prognosis until liver transplantation or even worse, it's around 13, 14 years. When you just take an average PSC patient in the somewhere in the country, in a hospital, and the patient asks you the same question, you should say to him or her, at least in countries as the Netherlands, but the same holds for, by the way, the UK, because Roger Chapman's cohort, which is also not a transplant center cohort, has exactly the same median survival. Then you should tell your patient it's about 22 years. So this is, I think, important information that that needs us to rethink how we should counsel our patients depending on where they're seen. Now, you've been told about cholangiocarcinoma yesterday by Dr. Taideh. You're all knowledgeable in PSC and know that cancer is a problem in this disease, so I should not avoid the topic, I thought. In, again, the Swedish cohort of 604 patients, which was in which Annika Bergqvist added more than 300 patients to the original cohort I told you about before, they found that the mortality was 28% and almost 44%. The cause of death was cancer, which means that in the 6 years of the follow-up they had, 12% of the patients died from cancer, which is not a very nice figure. When we look again to our cohort, population-based, 10 years later, a follow-up slightly longer, again, cause of death, 44%, cancer, which sums to about 7.2% in 7 years. That's 1% per year. That's half of what has been shown earlier. Now, cholangiocarcinoma cancer has already been discussed, but colorectal cancer, which makes up about 1/3 of the cancers you can find in PSC, has not been on the program so far. So I want to take you to a few numbers of colorectal cancer risk in PSC. Here, this is a graph of the cumulative risk of colorectal cancer in PSC patients who also have inflammatory bowel disease. Because when you don't have concurrent inflammatory bowel disease, the risk of colon cancer is virtually nil. And what you see is that the cumulative chance of getting colorectal cancer goes up with the years, amounting to about 13% after 30 years. And in a control group of patients with ulcerative colitis but no PSC, it's like 3%, which is the average risk of getting colorectal cancer among the, most of the populations worldwide. And this amounts to an increased risk in patients with both PSC and ulcerative colitis of 10 times as compared to a patient with only ulcerative colitis. And also importantly, the peak incidence where the patient gets their colorectal cancer is much earlier than in ulcerative colitis. It's at a mean age of 39 versus 59 in patients with ulcerative colitis. Now these figures are in line with a very big study from Denmark. The Danish have very good national registries. Every patient is in a registry, more or less. And they showed that, again, patients with PSC and ulcerative colitis have a 9 times increased risk of getting colorectal cancer as compared to patients with UC only. In Crohn's disease, there was also a slightly increased risk, but that was not significant, and at least it was much lower than in ulcerative colitis patients. So the question is in patients who have concurrent Crohn's disease of the colon, is there indeed an increased risk of colorectal cancer or not? Recently, among the International PSC Study Group, we started a really big effort to make the largest PSC database worldwide, which was coordinated by Tobias Weissmuller and Kirsten Boberg. It's called the IPSC Database Cohort, comprising more than 7,000 PSC patients from 37 centers in 17 countries. Really a big effort. The results are now under revision, but Dr. Weissmuller already presented some results during the ASLD meeting in November, where he showed that indeed there is an increased risk of getting colorectal cancer when you have concurrent ulcerative colitis and not when you have Crohn's disease, which is an interesting feature pertaining to management. Because what we need to do in patients with PSC and inflammatory bowel disease is colonoscopic surveillance. The guidelines, both from the European Study of the Liver and from the AASLD, prescribe annual or at least biannual colonoscopic surveillance in all patients with PSC who do have concurrent inflammatory bowel disease. And when you do not have a known inflammatory bowel disease, you should do a colonoscopy at screening and then every 5 years, because sometimes the diagnosis of inflammatory bowel disease lags behind up until 16 years or so in our cohort. And what you want to do is find lesions like this, which were previously called dysplasia-associated lesional mass. Please forget about it. We don't have a good denominator for it, but they're flat polypus lesions that are no cancer, but if you take them out, either endoscopically or by removing the colon, you will avoid the very high chance that these will turn into colorectal cancer. And the good news is, if you do that, if you do surveillance programs every year or every 2-year colonoscopy, and the patient would, and you would stumble up a colon cancer, but found into a surveillance program and not incidentally, the patients fare much better than when you don't survey them. So it makes sense, but what we should discuss in the near future is, should we subject all patients with inflammatory bowel disease to this quite rigid and not very pleasant, and you know that much better than I do, colonoscopic surveillance program, or should we differentiate and tell our ulcerative colitis patient, you should have your colonoscopy every year because we can avoid death from colorectal cancer, but when you have Crohn's disease, maybe we should do it every 3 years or so. So in conclusion, the incidence and prevalence of this disease, as was previously described, seems to be lower when you really look into a population-based population. But they do increase over time, probably as a result of the increasing incidence of inflammatory bowel disease, at least in Western countries. When you look in the population and not in transplant center cohorts, the estimated median survival, transplant-free survival, is much better. And there's an increased risk of almost 10 times in various populations studied now, at least when you have ulcerative colitis and PSC, warranting surveillance from diagnosis and not starting after 8 or 10 years after diagnosis, such as we do in patients who have not PSC but only inflammatory bowel disease. Now, is there a future of natural history studies, or do we know enough now? I think there is. What we now need to do is extend our retrospective cohorts, which we all built, into prospectively followed cohorts in which we can, in a structured way, much better collect all kinds of data we need to do new studies with. For instance, looking at efficacy of medication on the prognosis and symptoms. It's difficult to do clinical trials for various reasons, because they're little patients. It takes a lot of time before they reach an endpoint. But when we do observational studies, you can observe them as long as you will. And maybe patients who have inflammatory bowel disease concurrent to their PSC and get medication for that medication might have an influence on the course of PSC also. We don't know. You can get those information from observational studies. We could study risk factors for disease behavior, which will be touched upon by the next speaker, I believe. And also, we need to know much more about health-related quality of life issues. How much symptoms does the average patient have? Does it really respond to ursodeoxycholic acid or not? Our antipruritus medication, does it work? Does it matter what time you take it, in the morning or at night? We know too little about the amount of complaints you have, and for that we need to define better. And Dr. Aziz will discuss that in his talk. What we really need to look at with regard to symptoms and health-related quality of life, and that can be ideally studied in observational, prospective natural history studies. biomarker development, which biomarkers can tell us something about the prognosis or the effect of therapy in clinical studies, can be studied in observational studies, natural history like. Virtual placebo groups for phase 4 clinical trials is important. When we get to a drug that gets accelerated approval, it will need full approval by follow-up studies, but for that you need virtual control groups, meaning that you also have to take into account patients who never got the drug for a number of years, and for that these prospective natural history studies can serve. And also, of course, inception cohorts for recruitment into clinical study. It's important when we want to study new drugs or new therapies in specific populations, we need to know where are these populations, which are the patients that we can ask to participate. Do we have enough patients for that? Inception cohorts can be very useful. And last but not least, guideline implementation. When we for instance, find out that patients with Crohn's disease don't need an annual colonoscopy, but maybe every 2 or 3 years. We need to know where are these patients and who are the doctors that treat them, so that we can inform them that we change our policy. I sum up and I close by just giving you a small flavor of our next level Dutch PSC registry. We're now building up our prospective registry in the web-based internet era which we live in, with not only input from the physicians who take care of these patients with laboratory data and events data, but also from the patients themselves with health-related quality of life aspects, medication use and all that, and things that bother them, and they can file them every 3 months in a website secured environment. And also other data sources, for instance our national pharmacy prescription database in the Netherlands, which we can use to see if they really take their medication. And with that I would like to thank you for your attention.